We are now going into our third panel. Thank you all for coming back. And I'm really excited to introduce this panel who's going to discuss delivery of services and access to equitable mental health care. This panel will be moderated by Dr. Debra Houry. She is the Chief Medical Officer and Deputy Director for Program and Science at the Centers for Disease Control and Prevention. Over to you, Dr. Houry.
Well, thank you, and thanks to all of you for coming back post-lunch, post-break. We're mid-afternoon, but we promise this will be a really exciting and really robust discussion. I'm delighted to be here with the panelists today and to really summarize and take what we've learned from the day around etiology, drivers, different treatments, and to really focus on service delivery, how we can look at innovations around it, as well as what are the policy implications and how do we engage communities. As I reflect on today, I do really want to thank our planning committee and Victor for how the National Academy can really come around the crisis of mental health in our country. And when I look at the different sectors and sections that are represented here, it's really inspiring because we need all of us if we're going to make a difference. Whether it's clinical med, basic science, social science, allied health, we all have a significant role to play, and I hope that today we'll take what we're learning in these sessions and bring them back to our practices. I also want to just highlight, with my hat on as CDC, there's a role for public health and prevention to play in this, particularly when we look at the integration of public health prevention and healthcare. Thank you. With a lot of the funding that CDC's put out, we are seeing reductions in suicide and overdose, and I am optimistic as we've started to see declines in overdose deaths and really a plateauing or a slowing in suicide deaths. Certainly, those numbers are still staggering and too high, and that's why we have these esteemed panelists today to really tell us what we can do about it. So we're going to have Dr. Dakotah Lane, the Chief Medical Officer of the Lummi Nation Health Center, talk about a tribal innovative program and really how we can scale that to other areas. Dr. Kenneth Wells, an endowed professor at the David Geffen School of Medicine and a psychiatrist in the greater LA area, will talk about community-based partnerships and how do we engage communities around research. And then Dr. Anne-Marie Sullivan, Commissioner for the New York State Office of Mental Health, will take us a step up even higher to that state-level approach, looking at policies and interventions. And then Dr. Frank will bring it home for us, really talking about, as an Emeritus Professor of Health Economics in the Department of Healthcare Policy at Harvard, what is the impact of policy and economics on these interventions? So with that, I'll turn it over to Dr. Lane.
Thank you. My name's Dakotah Lane. I'm a Lummi enrolled tribal member. I'm the Chief Medical Officer of the Lummi Nation Health Center, and I'm here to talk a little bit about Lummi and our small little health clinic. We'll just go quickly. First off, most of y'all are all from the East Coast, probably don't know very much about tribes, reservations. You probably heard about them in high school. We're actually a very sophisticated entity. We provide a lot of health care. Lummi is one of 25 tribes in Washington State, and we are located on this small little spit closer to Vancouver, Canada, than Seattle. And we're pretty culturally diverse. Many of us think of tribes as kind of this group of people that our federal government dealt with. But as you progress from the east to the west coast, you get more and more tribes and the development of treaties. And the federal government made a choice to treat every tribe as a sovereign nation. Particularly at Lummi, we signed our treaty in 1855. Within that treaty, the federal government agreed to provide for health care. And I could give a whole lecture about tribal health care and all that, but we'll just move forward. Our tribe is about 6,500 enrolled tribal members. Roughly 2,000 are children ages 0 to 21. We have a tribal government. It provides all the same services that our state and city and, to an extent, the federal government. And we're culturally diverse. That's me right there. It's about 20 years ago. We fish. That's my little brother, Cheyenne. And then, of course, on the lower right, those are our war canoes. We have a canoe. It's called Stammish, and we do canoe races. So we're a very culturally rich tribe. The water is our way of life. So that's Lummi people in one slide. Moving fast, so I got a timer here. Lummi Nation Health Center. Our health center is a 50,000 square foot facility that houses multidisciplinary teams. Because we're a tribe and the tribe manages our healthcare dollars, we have a lot of opportunity for innovation. We also, as our treaty rights, and as my elders remind me, as my grandpa reminds me, we provide free healthcare to all federally enrolled tribal members. So not just Lummi, but any federally enrolled tribal member within the nation. We also cover any referred care to specialists. So if they go to a specialist, we make sure that is covered. If we don't, I hear from the aunties. This is just a quick list of all of our services. It's about 17. Just some ones I'm going to highlight is we do have adult psychiatry. We are building a child and adolescent psychiatry. We do have school-based health center. We have harm reduction, social work, physical therapy, dental. Those are just to name a few. We have our own pharmacy. So it's a very comprehensive center which everyone can get their services. All right, switching gears. Like the rest of the nation, we suffer from the opioid crisis. You see on this graph here in the blue is the numbers indicating non-fatal overdoses. Lummi made a decision in early 2000 to distribute Narcan for free. The police use it. We give it out to all of our tribal members. And what you see here is anytime a community member reports that they use Narcan, we just mark it down. It's not verified, it's very unofficial, and likely underreported. Unfortunately, in the smaller bar graph in the red are known overdoses. This year, since January 1st, we've had 6 overdoses within our community. It's extremely difficult, small community. Many of these are family, and we have no choice. We just have to keep moving and doing everything we can. This is a brief breakdown, roughly more male than female. Interestingly enough, the majority of overdoses are ages 30 to 69. So it's a middle-age overdose crisis, not necessarily the younger kids. In our clinic, so if you have a crisis, you have to have a treatment. So over the last 3 years, roughly 673 community members have opioid use disorder with charts at our clinic. Of those 673, 614 have received some sort of MAT, buprenorphine, methadone. And then within that group, 150 patients are currently active receiving office-based opioid treatment. We offer buprenorphine. We don't offer methadone. Okay, switching gears. A couple years ago, the CDC gave us a grant to focus on our opioid crisis. This is a model that was developed by our opioid team. You can see in the blue is the medical problem. In the yellow, orange, reddish circles are a social problem. And so this is, if you could design one drug to disrupt the entire civilization, opiates are it. And so what we notice is that it usually starts with some adverse childhood event, ACE, right? Many of us are familiar with it, and starts there. Then you go to teen drug use, you leave high school, and then you get pregnant, and then you have some drug-related crime. And then you circles back, the child's removed, and there begins the cycle. Then, of course, that person continues with jail, unemployment, housing insecurity, and all the things that come from that. I'm moving fast because my time's running out, so I'm going to go fast. So the opioid use crisis has significant impact in our community. In 2023, we have 53 children with a birth date in 2023. Of those 53, a quarter of them have been substance exposed. And then there's some more details there. 19% are developmental delay, 35% are premature, with 64% of those related to substance exposure. Overall, for the last 10 years, about a third of our children are born with substance use. So we had to attack the ACE scores. And when you run a clinic like this, a lot of people come to help, and you take opportunities when they can. We have a developmental pediatrician, Dr. Jenny McLaurin, who has a Center for Excellence in Autism Diagnosis. And so leading up to her, we had 82 children screened, roughly 59 of those that she diagnosed with autism spectrum disorder, including 14 which are related to level 3 diagnosis. Sorry, I'm just going to move fast. I'm sorry. We have behavioral health, 800 are active patients, 15 licensed mental health providers. We have 50 to 60 mental health appointments a day, same-day access, and we have crisis outreach. I'm going fast, I'm sorry. We will continue to improve care. We will link with Seattle Children's. They're going to send us a child psychiatrist. And one last thing. Council has decided they want a secure withdrawal management facility. In the coming future, we will be offering that to community members. And here's my contact info. I got 7 seconds left.
Good afternoon. I'm glad that we have a chance to talk about community engagement. What are the models that can be used in behavioral health, community-based participatory research, partnered research, with the example of community partners in care for an evidence basis and beyond. And I've acknowledged several people a community partner and some colleagues who've given input into the slides. Why community-based participatory research and partnered research? This has already been discussed in some of the sessions. Under-resourced communities face disparities in access, quality outcomes, and the same communities often have little voice in services or research or underrepresented. And community-based participatory research is recommended for program design and research by multiple federal agencies listed there from the CDC, NAM, and so forth. What is such an approach and what outcomes are there for behavioral health? This is the NAM model that recently was provided around ACEs and addressing mental health. You see the green in the middle, and that's the core principles of community engagement, which are very similar across multiple models to really engage, have a fair process, fair time to engage the community, fair resources, a co-equal partnership. This is the Wallerstein model. Her model is really internationally famous and used, and it really focuses on the context, which has been talked a lot about today, the quality of the partnership, leading to actions, interventions, and research relevant to the community, and then to have health, social justice outcomes that are tracked, as well as the partnership models. And this is another example of the PCORI model, which has a somewhat different way of organizing it, but similar principles, similar activities that are recommended for the partnerships. The model that we have followed in our work, community-partnered participatory research, and this is a picture of me with Loretta Jones, a very famous example of someone who has developed this model. You see the core principles at the top, similar to the NAM model: transparency, respect, equality, equity, power sharing, but especially two-way knowledge exchange. It's not the academic partners saying, oh, what input do you have to give me? It's two-way setting up the model, two-way agreeing on it, and then to have a structure with a council that represents the community and academic partners, to have working groups, Loretta would say no more than 3, otherwise it's overwhelming, to have a community forum so you don't go into it without bringing together something like this, inviting the community to say, have we got it right? And then in phases, vision, valley, victory, where vision is planning, victory is the hard work, valley, and victory is the celebration, the research, and so forth. And then community partners in care use this model with 95 agencies in Los Angeles County to address depression. This is a model of that community artist gave. And in that, the bottom is, there it goes. So agencies were randomized, that's the coin toss, to either agencies that the community recommended in both arms, churches, homeless shelters, and so forth, to work with healthcare agencies. And they were either individually given collaborative care for depression, evidence-based models, or worked together in the training and adapting collaborative care under the CEP arm, Community Engagement and Planning. And this is
So the moral of the story is, we all came together around a pot of depression, right? Came around a pot of depression, and we all have something to give. We all have something to contribute to the pot to address depression.
Does anybody have some screening that they can put into the pot?
Could you come up here and put it in the pot so we can have some screening in our
Okay, so that gives you a sense, and actually the minister that came up said, we need love. And I thought this was exactly what Vivek Murthy said. So we found that this engagement approach led to more participation by staff in collaborative care trainings in all aspects of collaborative care. We found that in 6 months, and patients were recruited from all these sites, or clients, and there was improved mental health, quality of life, and physical activity, which was a prediction of the community, which is why we measured it. There was reduced homelessness and risk factors for homelessness, also a major thing that the community asked us to add, and then fewer behavioral health hospitalizations. Longer-term outcomes and outcomes for subgroups. So at 12 months, there was improved mental health again, fewer hospitalizations again. At 3 years, the community said there would be improved physical health. If my mental health gets better, my physical health would get better. And that's what happened. And there were also still fewer hospitalizations. And then at 4-year follow-up, there was more community-defined and traditional remission. There was, for women, reduced homelessness, financial difficulties, justice involved, fewer arrests, substance abuse, less hazardous drinking. And then dissemination and beyond. The Cochrane Collaborative Review said this was the most evidence-based example of the added value of community health, of community services in health in the world. And they were thinking of doing later another review, and they said, no, there's been no change. It's been applied to post-disasters, digital health tools in California during COVID with community-partnered input, and the Community Learning Institute to really train community partners to be co-equal with academics. Jürgen Unitzer did the Care Partners, which is applying a similar model to the elderly, showing 50% reduced depression in the elderly. And then the key to the future, as has already been said, it takes all of us working together. And I think really bringing community engagement, I mean, now already has that for some of its panels and so forth, but they could be at a meeting like this too, along with us, to really engage in the goals for achieving equity. And so thank you very much.
Hi, I'm Ann Sullivan. I'm the Commissioner of the New York State Office of Mental Health. And I'm going to take you through what we've been doing in the state of New York to transform the mental health system with a very supportive governor. And I can't emphasize enough how important that is, that policymakers, we can come forward, but when the administration of a governor is on your side and gives you the dollars to do some of the work, you have quite an opportunity. So the vision for this really includes, I'm not going to go through this in detail, but a couple of key principles. One is you get a lot of stakeholder input. We did surveys across the state. We spoke with lots of people. We spoke with people with lived experience. Nothing about us without us is an important saying that we always have to keep in mind. So it's very important to get the input into what are the gaps? What isn't working? What do we need? And then we need to think about it in terms of holistic. Medical, substance abuse, mental health, and developmental disabilities, which is an interesting issue in New York State, and that also has been an isolated group with dual diagnosis. So you put all those things together, you want an accessible system of care, and you want all those values to be embedded into your system of care. So we came up with 3 big buckets, and I'm going to take a little extra time talking about prevention, because that's been a topic today. So on prevention, we thought of 3 big things you had to do. One was schools. We've talked a lot about schools. So we made a commitment to put a school-based clinic in every school across New York State. Now, we're not there yet. We have 1,200 clinics across New York State. We've got about 4,000 schools that need them. So we need to get more of those out there, but we have a commitment to do it. And what do? They provide services in the school, but they are a satellite of a community-based clinic, so they can provide that kind of transition and holistic care, which is really exciting. And where's the other important place? It's pediatricians' offices. There's an evidence-based pediatrician program called Healthy Steps. Healthy Steps puts a mental health worker in a pediatrician's office who has 1,500 or more families. Seems simple, doesn't it? Just have someone there who can work with the pediatrician, work on stresses, especially early. Their focus is on 0 to 5. So it's that early prevention, looking at things before you have a diagnosis, and hopefully you don't get to a diagnosis. So we've supported that. We're supporting it for over 300,000 families in New York State. We keep growing it. I would love to get it embedded into the Medicaid benefit. It's pennies, guys, pennies on the Medicaid benefit that would help a pediatrician to have that in his office. And that would work with your ACEs, all the kinds of things that research has told us is so important to deal with, but we've never implemented. So that's one thing. Get those guys into pediatricians' offices. And then the third is special populations. And, you know, this is where grassroots organizations teach us something. So for Latina adolescents, you saw that really very sad data about suicides. Basically, there's a program which we're now making statewide because it was begun by Community Life, an organization in New York City, where they work with teenage Latina girls who have suicidal ideation. They're not doing therapy. They have that someplace else. They're doing after-school work. They're helping them to become young women. They're helping to empower them. They're helping them to see choices in life. Funding that should be funded just as much through Medicaid or other payers as anything else. So we've done it, they did the research to prove it was evidence-based, so now we're expanding it across New York State. So that's where research, putting it together, and now we're still paying for it out of general funds, but eventually we'll get it on Medicaid. Community access, I'm just going, oops, let me go back. The second big bucket was community access, and here I'm only going to mention one big thing with this, are the Certified Community Behavioral Health Centers. They're the FQHCs of psychiatry. They are terrific. They're cost-based. They improve access. I've got some data I'll show you about them later. We tripled those in New York State. And then the third big bucket was to work with the most vulnerable populations. And in a while, I'll talk very briefly about one particular population that we forget about. Well, we don't forget about, but we kind of walk past, which are the unsheltered homeless on the streets throughout our state. So diversity, equity, inclusion has to be involved in everything. How do you do that? You start it from the beginning. It's in your RFPs. It's in the way you fund. It's in the way you choose who gets the money. And then you also need to follow some data to make sure that it's being followed, and that's where I'm going to talk about a data dashboard quickly. Okay, the data dashboard. Oh, I know it's a bad slide, but basically what it says is you take Medicaid data. This is all in Medicaid data, guys. Every health plans have data on outcomes, clinical outcomes, medical outcomes, psych outcomes. You take that data, not perfect, but still gives you earmarks. You take it divide it down by ethnicity and race, and then you look at it across the state. And then you make it available to the clinics who are providing the services. You don't keep it in some treasure chest in New York State. So this is data that just shows across New York State adherence to psychotropics for individuals with schizophrenia. It shows whether or not you take your antidepressants regularly. But we also get medical data. And this is comparing across the state by race, ethnicity, who's getting colonoscopies. Important. And if you look at this one, what's the biggest discrepancy in colonoscopies? It's men and women. Women get them, men don't. And if you put that other graph on top, you would find out that for Hispanic men, way on the bottom. So how much of our clinics, our work in behavioral health, are paying attention to this kind of data? They don't know this kind of data. We need to get it out to them. They need to see, are all their populations getting treated equally on these critically important issues? And the only way to know that is if you give people data. And the data's there. It's a sense of mining it and getting it out to them. Next. CCBHCs, just wanted to give you the data on CCBHCs and why they're so good, because they basically decrease hospitalizations and they get new people in. And they're also cost-based. So basically, at the end of the year, you add up what it costs to do the work, and you get paid, versus struggling to try to make it work. The CCBHCs have made a difference nationally. Now, just a few words about the street homeless population. We did this with, in New York City. About 2,500 individuals live in the subways and around the subways of New York City with intensive wraparound teams. that think about someone's hopes and aspirations, that think of what they are capable of. That was said earlier today, too, by Dr. Vivek. Everybody has hopes and aspirations. Everybody has goals. So do individuals living on the streets. If you work with them from that premise, we were able to get 700 individuals permanently housed, most of whom had been on the streets greater than 2 years. So you can do it, but you need teams, you need people who follow up, and you need an approach that says that individuals can think beyond where they are, and you work with them in a way that we hadn't in the past. And then lastly, just a quick word about the crisis systems, which are happening across the country. And someone said earlier, well, how do you begin with prevention, was one of the questions. Well, I think 988 is super prevention. 988 is a number that you can call early. You don't have to wait until you're in a suicidal crisis. You don't have to wait until you're having a mate. You can call because you're concerned that maybe your son or daughter isn't doing so well in school, and how can you get help? 988 is a counseling line. 988, the average time people are on 988 is 20 minutes. It's not a quick call and hang up. So, and you can call back, and you can get follow-up, and you can get referrals if you need it. So 988, offering that offers people the opportunity to begin to access services, because one of the biggest problems we have is people don't come for service early enough. It's the same thing as getting your screenings for health. If you don't get the mammogram screenings, you're not going to know that you have breast cancer. If you don't call 988 and say, I'm worried about this, do you think I need help? You're not going to know. And that's one of the huge preventions in mental health, is having easy access to questions. But you have to build around it a system of care, which was the rest of the slide, and now I'm out of time. But thank you.
Thank you for having us today. In the time I have with you today, I want to deal with three economic policy challenges facing mental health in the United States today. They're as follows. First, a concern about how we define need and how we link people with mental health needs to care. The second one focuses on what I see as weak accountability for access and quality of care system-wide. And then the third concerns how we spend money on care and support for people with serious mental illnesses. I'll conclude with some suggested economic policy actions that might be pursued to improve matters in each of these three areas. Let's see. Let's start with need and the matching of people to treatment. The Venn diagram that you see in front of you is in a sense based on epidemiological surveys, and it shows the overlap between people who have various indications of need for mental health care, and I chose three groupings here. First is people with a diagnosable mental illness, which is about 21% of the population. That's a very well-known number. The second is people with functional impairments associated with symptoms of mental illness, and that's about 17.5% of the population. And then finally, there's people who receive treatment for a mental health problem, and that's about 19% of the population. And what you'll see in the Venn diagram is that the overlap is relatively modest. And that suggests both a potential challenge in how we think about need and also a potential allocation problem. And that's particularly true given the following. First of all, about half of the people with a diagnosable disorder get treatment in a particular year. Second, 30% of those experiencing a functional impairment due to a mental health problem get treatment in a year. And then about 29% of the people who get treated have neither of the other two. Let that sink in for a moment. So here, it's important to remember, and I think this has been brought up repeatedly today, is that within each of these categories, there's a tremendous amount of heterogeneity. People with a diagnosable illness or a functional impairment are very different with respect to their life circumstances, their level of disability, the impacts that the treatment will have on them, and the economic resources that they have available. All of these challenges make linking people to the right care challenging. Let me now turn to accountability. Let me go with health plans first. Now, health plans continue to make a profit by adopting practices that avoid enrolling people with mental illnesses and substance use disorders. Enrolling these people is seen as financially disadvantaged, and so they don't do it. There is very limited use of behavioral health quality and access metrics in assessing and rewarding the performance of health plans. For example, Medicare Advantage, which is now over half of the whole Medicare program, does not include any behavioral health performance metrics in its quality bonus program that basically attaches money to performance. Likewise, on the commercial side, commercial payers make very limited use of the metrics that are out there in rewarding performance of commercial health insurance plans. And finally, access metrics like network adequacy standards are at best minimally informative and in many cases obsolete in a world of telehealth. Now let me turn to providers. While clinical science has continued to march ahead, as we've heard throughout the day, the use of evidence-based treatment has actually declined over the last 15 years. Reviews of training programs have shown a very weak relationship between training in the major professions, social work, psychiatry, psychology, and evidence-based treatment. And finally, clinical activity is very poorly measured and infrequently subjected to quality-related oversight of any kind. Now, let me turn to the way we spend our money. Now, the U.S. Devoted about 1.1% of gross domestic product on mental health care in 2020-2021. In 1975, they spent 1%. Conclusion, we don't have a cost problem in mental health. Let's take in contrast what we see on the overall healthcare side. 1975, we spent 6.5% of our gross domestic product on healthcare, and in 2021, it was about 18.2%. They have a cost problem. That's different. Looking inside the mental health spending, we spent about 28% of our dollars on supports for people with mental illness, and what I'm mostly serious mental illness, and what I mean by that is housing, employment supports, income support, and human services. Australia, Denmark, and most of the EU countries spend about 65% of their mental health dollar on supports. The crude evidence suggests outcomes for people with serious mental illness would likely improve with an adjustment to that mix moving towards our OECD partners. So what do? In the words of Uwe Reinhardt, who was a prominent member here, economics is common sense made difficult. So what I'm going to do is I'm going to give you 5 really simple ideas that are going to be really, really hard to implement. So the first one is pay health plans for enrolling people with mental illnesses, and especially ones who are really sick. Pay them more, and that means taking risk adjustment seriously, which we haven't done ever on the mental health side. Second is attach financial consequences to quality of care for health plans, reward plans that arrange for good care, and penalize those that don't. Third, hold health plans accountable for access to care outcomes, not measures such as network adequacy. Set standards for what you think population-based access should minimally be, and then hold people to them. Measure provider quality at the provider level, and steer patients to those clinicians that provide good quality, and steer them away from those that don't. And finally, drive public programs and budgets towards greater emphasis on housing, employment supports, and other social supports. And I'll stop there.
Well, thank you all. I just wanted to ask each of you probably a brief question, and then we'll open it up to the audience for more engagement. And Dakotah, I wanted to start with you. And one of the things that really stood out to me is, when we're looking at evidence-based practices, we want to make sure we're meeting people where they're at. Tell us a little bit about how you've been able to bring in cultural practices and really meet people where they're at so that your programs are effective in showing the results that they are.
Great question. I ask myself that every day. One of the struggles that I had when I first arrived is, as a primary care provider, you can make the diagnosis, but knowing what to do after is actually harder. So our clinic has grown from about 80 employees to 200 employees, and what I was really brief on the slides, but probably the most beneficial things that we have done is we've hired a lot of community members who have lived experiences and are now in recovery, and they're stable. And so, for example, to mental health care, opioid use disorder, we have two different teams. We have a medical social work team with what we call peer counselors, and those are actually tribal members. A couple of them are my cousins. And then we have the behavioral health crisis counseling. I was real brief, but we have about 80 crisis outreaches per month. A lot of them are repeat patients. And so as a physician and a tribal member, trying to encapsulate all of those demands of the community and the culture is I can make the diagnosis, and this person now has some big social housing. There are a few that have no water, no electricity, no heat. When I was in med school, one of the things that I remember hearing was, insulin, and why aren't they taking their insulin, and why isn't this patient taking insulin? And it turns out they didn't have a fridge, or they had a fridge but no electricity. And so then, thankfully, Ozempic saved us from that. We don't have to deal with insulin quite as much. But that also means reaching out for the electricity, water, heat. We reach out to the tribal arms, government arms for paying for electricity just for the winter. When COVID was around, we got this huge influx of air filters. So then we just gave air filters to all the families so that we could help reduce the spread of COVID. And a lot of times communities, and I'm speaking both for my community, but any community, marginalized community, there are people who want to help. And as professionals, all of us here, we should listen to them. We should hire them. And use them and use the connections. And I'll just finish with this last comment. I have a really good friend who's a paramedic, and every time he drives by one of those homeless people with the sign, and they're young, likely have some substance use disorder, he mentioned it probably takes about 20 people just to get that person to go into recovery. And I agree with that. I look at my team that I have about 20 people in various capacities, from nutritionists to our social work outreach to the tribal government, that will go out into the communities. We know where everybody is, and so we know where they live, we know which homeless encampment they're at, and so that's, the amount of social resources and social capital that we have to invest. And that's how we have oriented my clinic. I would like to be the one to take credit for all this, but I'll be honest, a lot of this comes from the council, comes from our elders, it comes from cultural expectations, and then navigating that. So, long answer to your question, but I hope that answers some of it.
No, it does, and actually I'm going to go out of order because, I wanted to pick up on something you said, and that's around some of the wraparound services. Okay. And Anne, as you were looking at state-level approaches, what struck me on some of your slides was, it's not a single intervention. It's not just a medication or a cognitive-based therapy. Tell us a little bit about how you were able to bring in the wraparound services and how that really helps with return on investment.
Yeah, I think it's critical, as Dakotah was saying, when especially high-need individuals, they need a lot. They need social supports, they need environmental help, they need housing. We have a huge part of that budget was to put housing out. So you need housing. You need a housing first team that can help individuals who haven't been in housing for years maybe come into housing directly from a crisis situation or from the street. And then you need to have teams that work with people and stay connected with people. You know, relationships, when we break relationships and move on to something, you know how hard it is if you move to a new location, and yet we've set up a system where individuals are expected to step down from one relationship to the next, and just reform relationships. Individuals who've had trouble doing that. So a key thing about the wraparound services is to make sure that those relationships stay intact and that people have someone who goes with them through their journey. And our success with individuals leaving hospitals who are acutely ill or coming into housing from the streets is having those intensive wraparound services that look at everything they need. Maybe getting a meal that night is more important than anything else. Medication may be there somewhere in the distance, but it may not be the first thing you ever talk with anybody about when you're trying to engage them. So it's manpower, it's social input, it's what you were talking about, it's intensive work, it's hard work, and it takes a long time to connect. But those wraparound services are critical. But you need, I think a basic one is housing. I think if somebody doesn't have a safe place to put their head at night, where they can go home, then a lot of the other things we try to do are not going to be very successful. So housing is critical. Connecting with a provider, connecting is critical, and then getting your healthcare services, et cetera, connected. So when you're dealing with individuals who have disconnected from the system, it's critical to have those kinds of services available. But then you begin even early on. I mean, even a family who comes into a pediatrician's office, they should have those wraparound services too if they need them. They should have the ability to have someone to talk to if they have a mental health problem. They should have a social worker who could help them get what they need. You need to have those services easily and readily available. That's the goal of the CCBHCs and others. We don't always are successful with it, but it's critical work. And it needs to be funded. And from what you were saying, often these kinds of services fall in the question mark area of funding from Medicaid or other sources. And so sustainable sources of funding for these services is critical.
Okay, I see Ken wants to
if I could just add, so in the collaborative care expanded model that we did, then you can imagine what happens if Parks and Recs and the faith-based providers being trained in depression care along with the primary care, right? And then when the primary care has, let's say, the patient that they know needs, they say, oh, you can go down the block, and at Parks and Recs, they will train you to exercise, and they know what to do with people who have this condition. Or the minister is someone they trust to reveal it with more than their primary care, or the barber shop. So bringing them all together and training them together is what allowed for those kind of outcomes that we talked about with homelessness reducing. It's because the homeless shelter was there being trained along with the primary care so they could work together. I just building on what you're saying.
Absolutely.
And there are models of that, even free online, the modules from Community Partners and Care about how you do that. It's sort of like training peers, but there are people out there in the community already relating to these people, right? Anyway, just a comment.
No, totally agree. And I'm going to take what you're saying and now turn it to Richard around workforce, because you were talking about, training people that maybe to do things differently.
If I could just make a point that Richard could comment on too. So, of course,
we're going to come up with a list for you.
To do that, that co-training and all that requires some funds, right? So it might be a more expensive model. On the other hand, because it reduced hospitalization, the cost was not higher. And Richard said, Ken, you should say that's cost effectiveness. So, I think it's important to track that, because even though it can take more input, if it reduces the cost of healthcare, the overall costs are not greater.
Thank you. So we know it's not just about the money. So tell us about workforce and some of the other issues.
Well, it's interesting. Dakotah's the exception here. He has a completely separate financing world than everybody else in this room. And so I'll just address my comments to everybody else. the first thing that people who work with Ken think about, people who work in New York State think about, is how are we going to get Medicaid to pay for this thing, right? And we have a very distorted funding scheme because, in fact, you don't necessarily want Medicaid doing housing. You like housing people doing housing. And so until we start to sort of align our funding where we think the payoffs are in terms of improving the health outcomes, we're always going to have trouble, because when you do your day-to-day job and you're trying to get your budget to go somewhere, you're going to go to Medicaid. You're not going to go to housing, because the housing, the 202 program, the Section 8 program haven't grown very much in the last 20 years. And so we have to start thinking differently about how we align our funding, particularly for these populations that are so sensitive to the impact of those services.
And just to clarify, I mean, I think recently Medicaid has agreed to pay for the supports for housing. That's what we're going for. I mean, we understand that the housing per se is probably not going to be paid for by healthcare. However, the supports that we wrap around should be. And that recently Medicaid has made significant steps to go forward with, which is good.
Yeah.
And I agree with you, though, that the housing problem nationally is huge, and those funds have dried up.
Right, and it's true on a variety of other things. Housing is the easiest one to pick on. But I do think that certainly for people who've been in the federal government, first thing you do is you think about how you're going to get, the homelessness people talked about how they're going to get Medicaid to pay for it. The disability population is the same thing, and it's because we've distorted the rules of the game.
I saw Dakotah wanted to add.
Yeah, so the business model for my clinic is slightly different than the majority of healthcare here. Half of our funding comes from the Indian Health Service, which the tribe manages. We're a self-governance tribe. The other half we have to make up by billing private insurance. 40% of our tribal members are Medicaid eligible. The rest are done by private insurance. And then with regard to housing, I'm speaking purely for Lummi, but I suspect a lot of homeless people are in the same boat. A lot of them in Lummi, you can get, because of the tribal government and the housing that we have and the expectations, you can get housing if you choose to be sober. And the ones who are homeless are making a choice to not be sober. Using feels good. Like, there's a reason why they keep using. Particularly in our community, when I talk to people who use, they want to do two things. One, they want to suppress some mental health, depression, some trauma they faced that they don't want to deal with. They take because they are homeless, and it's really hard for them to get out of it. And so for me and our clinic, we focus primarily on treating their substance use disorder. If we can get that substance use disorder, then we can start moving to housing. I know Lummi also is thinking about low barrier housing, where people can, because we get a lot of our grants from the federal government, HUD. They require us to do urine drug screens, and so if you don't pass those, you don't get housing. So we're moving, Lummi, the government is moving towards offering low barrier housing to try to get people at least in housing, and then maybe we can start treating them because they are a transient population. It's super complex, and our team strives to, as best we can, meet them where they're at, while at the same time holding them accountable for their actions. That's where we come from. It's a little, it's really uncomfortable. I'm not gonna, it's dealing with people who choose to use is uncomfortable.
Well, thanks for that. We're now going to engage the rest of our colleagues in the discussion. And we'll start with you, Dr. Jones.
Hi, Kamara Jones. So Dakotah, are you saying, so I am not in the substance use disorder, not even mental health, I'm not, okay. But I do know that it seems like many years ago now, there's been kind of a housing first approach to dealing with unhoused people, and it sounds like the Lummi Council strategy is other than that. If I hear you, that they have housing if they choose to be sober. Have you guys ever discussed changing that or something? Because I think there's evidence, I'm not sure, but I think there's evidence that if you have people who are unhoused for whatever reason, if you can get them in housing first, then you can start dealing with the mental health challenges or the substance use disorder challenges, and it's more stable. So I'm not in the field, but I just have heard the housing first works, and I just heard what you said, so I'm interested in your response.
Yeah, so a lot of our housing grants comes from the federal HUD, and they attach, like anything you take from the federal government, they attach a lot of requirements, one of which is you must be sober. That's the...
They do it.
Yes. The federal government.
The federal government, but okay, am I wrong? Like, haven't people demonstrated that a housing first approach works?
I'm with you. Yeah.
Okay.
So Anne's going to jump in, and then we're going to get through all the questions. There's so many excited people
There is
lined
good
up.
evidence that housing first works. Often that housing is paid through other mechanisms. So, for example, we have a housing first model in New York, but a lot of that is it's money paid by the state. So you do get into convoluted issues when you're dealing with the federal government, but housing first model is evidence-based, it's been shown to work, all that kind of stuff. But it depends on your source of funding for the housing, whether you can use that model or not.
I agree with you. Housing first, if we could just give people housing, that would definitely help their recovery. But the operationalizing it and working with the grants and requirements of grants is what we're navigating.
Yeah. But individual states can decide on some of that for Medicaid.
Yeah.
So LA County, for example, has Housing for Health, which is under Medicaid.
Yes. Yes, it depends on where you're getting. It's complicated. It's where you're getting your money from. So we use it for Medicaid, but the HUD is another funding source, and they have certain rules.
Yes.
The only thing I will say in defense of the federal government is that it's not always up to us. It's how Congress may appropriate our budget in some matters. And we certainly do look for flexibilities and way to work across agencies, so point taken. But just want to remind everybody there's a lot of people lined up for questions, so focus on the question, and then we will have our panelists engage. We'll go to this microphone.
I'm Larry Green, Farley Center in Denver, Colorado, at the University of Colorado. I have really enjoyed today, and I wanted to say thanks to the program committee and the staff about this. This has been really a coherent and stimulating series of panels. What I am going to take home with is two things. One is, over and over again, we have heard our speakers say, we need to work together. I think the word together must have been spoken at least 100 times. Yet we're selected by our disciplines and our tribes and all that sort of stuff. So the second thing I'm going to take home is that there is a proven research method called community-based participatory research, which Dr. Wells is, you guys are exhibiting again. It works. It shares power. The room is full of power, but the people with the problems that we've been talking about are not here. In participatory-based research, we would have them in the room with us right now. So I want to make a request for the consideration of our NAM Council, our senior leadership, next year's program committee. Think about getting the people that are experiencing suffering, have needs for the problems we're talking about in the room.
Thank you.
Jeffrey Lieberman, Columbia University. I have a quick comment and two quick questions. First,
Let's go with one question because we have two other people lined up.
well, but they're both going to come to Richard, so he's very succinct. First, a problem is we heard a great research panel today about this rarefied research, which is going to take years to be able to come to translation and application. It's not a criticism against the fact we need more funding for research, but we don't use what we already know. It's not being implemented. That's the comment. The question, government's responsibility towards this population is a variety of things, protect the people, but to provide health care. We don't do a perfect job of providing health care, but we do a reasonable job of providing health care. But for mental health care, it's abysmal. Okay. Why is it abysmal? It's abysmal for a lot of the reasons that Richard pointed out. We lack an infrastructure. We don't have a continuum of care. We don't have a trained workforce. There's not accountability. And we don't have a reimbursement system. We have great prospects. The Lummi system, which I never heard of, sounds very interesting. Ken has been a long-time pioneer. These are one-offs. The process of trying to scale them up is a challenge. So it would obviously be more efficient to have a top-down macro approach, which we don't have. So my question is, we ran a panel several years ago where you shot me down with this. Should this be a national priority where the resources required are allocated for mental health, since now it's on the radar screen? Second question, much more succinct. You mentioned PCORI, Ken. What's PCORI supposed to do? I thought they were supposed to have comparative effectiveness studies funded, and I'm not aware of the fact that's been the case. Case in point of why that's relevant, you probably heard in the news about Cofemfi, a new drug that was developed, one of the first ever to have a new mechanism of action. Bristol Myers Squibb purchased it for $14 billion. Great scientific breakthrough. It's going to be released. Nobody knows how to use it. Monotherapy, combined adjunctive therapy, what populations to be targeted with. That data of how it would be used in the real world is not available. It's going to cost $20,000 a year, which will add to the budget. Should PCORI be mandated to fund comparative effectiveness studies? Or if not PCORI, some other agency?
So big questions. I know you're going to be brief because we've got three other questions.
Well, just appealing to our prior speaker, we're in this together not only in the community side, but also on the policy side. So be good if the clinicians decided to stop opposing getting measured. It would be really good if taxpayers would be a little bit more willing to support mental health care. Politicians need to be made more aware of a set of issues, and we need to have kind of good, simple ideas. And I think that there's plenty of room for innovation elsewhere. I mean, what's striking about today is that, I was saying this to Victor, is that in the prior panels, we got to see what a Michelin star, 3-star restaurant looks like. And today, in this session, we're talking about how to get K rations to everybody who's hungry.
I think that is an amazing takeaway quote. We'll go to this microphone.
I want to thank the panel for a great discussion. Terry Vandenhoek, University of Illinois, Chicago. So a couple of you have mentioned the importance of adverse childhood events, the personal cost and the cost to the health system. Could you talk just a little bit more to the question of, are there ways to prevent ACE, and are there treatments that can be effective for the trauma of ACEs? In the emergency department, we see the consequences of that for decades in terms of what patients present for.
Yeah, great question. So this is pretty relevant to a lot of Indian country. And this is, in my opinion, took generations to create those adverse childhood events. In our particular case, I don't think it was necessarily the removal of us onto reservations. I actually think it was the boarding schools. Take away kids from their parents is never a good thing. And to then make them speak different languages is never a good thing. My own great-grandma, my grandma Dora, refused to speak our Lummi language to my grandma, and then also stopped giving her a lot of cultural things. So from to traditional names, I got my Indian name from my grandma. Mamusia is my name. And so now we're trying to rebuild it. And so I've been wrestling with ACE scores ever since I started working in my clinic, because it's a great like predictive value. It's great at telling you like you're going to be depressed, you're going to more likely develop all these downstream mental health disorders, but it's not really good at telling us how do we stop it. And it goes back to that model that I had earlier of the circle with the medical model to the social construct model. There's really only one way to do it, and this was touched upon in the previous discussions, and it's right at conception. 30, as I mentioned, for us, 30% of our babies are exposed. And not all of them are on MAT treatment, which is the current evidence-based standard with good outcomes. And it's all the other things that come with it, right? So more likely if you're, addressing housing, which is important, food, and all those other things is just trying to demonstrate to the child that they're valued in a community, that they can receive the right nutrients. And what we chose in this particular case is getting better services to those children who have been exposed with our developmental pediatric program, getting those diagnoses early. The next step that I didn't really talk about is getting ABA therapy to all the families that have those children who have developmental delay or some sort of other issues that we have, autism. And if we can get help to those families, then we're one step closer. But I've come to the conclusion that it took generations to get here. It's just going to take another couple generations to fix it. And I'm just trying to put in place the things that will allow my kids, my grandkids, and my cousins' grandkids to have success in today's society. So it's a long answer. There's no silver bullet.
I think Anne wants to add quickly to it.
I don't think there's a bullet, but I do think that we're going towards looking at screening in a way in pediatricians' offices. Now, they're going to say, well, it's too much work or it's too hard to do, or what if I find these things? But if you don't know that they're there, you're never going to do anything about it. So, for example, the 1115 waiver, which is coming from the feds to New York State, the Department of Health is going to be encouraging certain kinds of screenings in pediatricians' office that will identify the problems that lead to the ACEs. And if you then can identify those problems, now you have to decide what you're going to do about them. And yes, it's not easy to decide what to do about them. But if there's alcoholism in the home, or if someone's lost their job, or if mom's depressed, we know that kids of depressed mothers are more likely to be depressed. That's one not easy, but that's one place you can look right away. If a mom's depressed, help her. Get her less depressed so that her kid 10 years from now won't be depressed. So those kinds of things you can begin to do, and it's starting. Now, if you do it, you have to have a plan for what you find, and then you have to work. But what is often, there are more sometimes, not often, but sometimes there are services available that, for example, people don't know about, and then you need to help them get to them. But I think we're beginning to move towards it. Our pediatricians spend an enormous amount of time checking everything physical that can be going on with a kid, and they need to look at what's happening in the world the child's in as well. It's just as kind of important. So got to help somebody, and that's why I say put someone in the office with them to help them do it. But I think that's what we're going towards, is paying attention to early methods of screening, and then you have to be careful that the screenings that you do are culturally acceptable and really tell you what's really going on in the community.
The only thing I would just add is at CDC we do have a resource around ACEs, and it can be done at the macro level, things like policies, earned income tax credit, paid family leave, all of that has been shown to reduce ACEs. You can look at community level mentorship programs, things like Big Brother, Big Sister, child like intervention programs in schools, curricula around conflict management help, and then also looking at things like nurse family home visitation programs. Those are all improvement to reduce ACEs, and certainly, like Dakotah said, linkage to counseling, if you've experienced ACEs, can lessen them. We'll go to this microphone, and then I think we've got time for one more question after that if we are quick, because we have a hard stop with the President's Forum.
Thank you. My name is Claire Wong. I'm a former RWJ Policy Fellow and currently serving in the state of Delaware in the Division of Substance Abuse and Mental Health. My question is probably for Dr. Sullivan and Dr. Frank. I'm interested in knowing your thoughts about, in terms of holding payers accountable, holding health plans accountable, and also attaching financial incentives for high-quality mental health care. What works? In your opinion, if you can only say one thing, what are the most effective and feasible levers at the federal and state level?
I can give you a few examples of what we're trying to do at the state level, and it's tough work. It's tough work. First of all, you want to enforce your parity legislation. Parity laws have been on the books for 20 years, but were skirted by insurers for a long time. So you've got to work on that, and we do have a whole legal force in New York that fights parity violations. The other areas are coverage areas. And I think two things. One, it's piecemeal, sadly, it's piecemeal, but we've actually had to put into legislation that you will pay for school-based services, commercial and Medicaid, no questions asked, that you will pay for crisis services. Now, it may seem odd that you have to put that in legislation, but we found that just working with the insurers didn't get us anywhere, so we put it in legislation, and that has become real. We also forced them to pay at the Medicaid rate, commercial payers, for our clinics, because they were getting paid at 2/3 by the commercial payers, which is very interesting. And then lastly, there are insurance regulations that you can use. And we were hoping this will happen, it's very close to being put into force, is next year that you have to have an appointment within 10 days for a mental health visit. You can't wait any longer than that, and there will be sanctions if an insurer doesn't provide a mental health visit within 10 days. That's for a general visit, different things if it's very acute, but 10 days. We all know about waiting lists. We all know about phantom directories. So if you can get your insurance regulators to say that, sorry guys, you have to provide this, and if there isn't, there'll be sanctions. So when you don't follow the rules, then you have sanctions. It's a very laborious process. We like to negotiate with the insurers rather than have to do legislation or regulations. But if your negotiations don't work, those are tools you can use.
Thank you. We're going to do one more final question, then we'll continue the conversation later at the reception with the panelists. But final question.
Good afternoon. Thank you, Dr. Lane, for doing an excellent job of explaining tribal health. I am a Navajo nurse midwife from New Mexico. The question I have for you is, how did you support or design your organization to support your staff to be trauma informed? Because oftentimes I have found that my coworkers had experienced anxiety, depression, and PTSD, and often didn't showed signs of being disgruntled or having a hard time getting feedback. So you talked about hiring the community and people who are in some form of recovery or further along in their healing. But what I have found in that type of space is that the organizational structure isn't set up to take care of people who've experienced trauma, which technically we all have. And so as an organization, oftentimes as a healthcare provider too, we look out as like, we're gonna take care of the community, but how is the organization taking care of us? And so is your organization set up in a way to also be bi-directional in healing? I would find that to be equitable.
Great question, and I certainly could talk a lot longer than 1 minute on this, but the short answer is I do training, do a lot of meeting with them privately if they're having some concerns, both non-tribal and tribal. We have an annual trauma-informed training. Sometimes I take non-tribal members out and we go into the community and we get the chance to meet with people. And then I've also developed along, I kind of briefly touched on it in my presentation, tribal health and the history of tribes. You have to start from the very beginning, from the founding of this nation to understand how it transgressed all the way through our families. You and I, we have a long oral history. We heard from our grandparents, but not everyone has that. The flip side of that story is my mom's white. I'm a pure product of America. And I can't speak for you, but certainly you're from this country. And so, like, I have two different stories. I have a story of my grandparents on my dad's side who lost our language because of the boarding schools. I have the story of my mom on the white side who immigrated over here, had all kinds of economic success from having my dad's side move on to the reservation. So, like, I straddle this weird boundary, and I have to navigate it, and I navigate it with my staff. That's my best short answer, and the light's blinking, so I'm really sorry.
Thank you all.
Good job.